I'm sure there'll be some more people kind of trickling in. One of the last sessions went a little bit long. So I'm super excited to introduce you today to this amazing topic and looking forward to hearing about it, integrating artificial intelligence into lactation and breastfeeding support. We have here Dr. Jessica De Souza. She's a PhD researcher who achieved her PhD in electrical engineering with medical devices and systems. Her doctoral research in digital health technologies lab focused on advancing equitable access to lactation support through the integration of artificial intelligence. We also have Christina Chamberlain, who has her master's in nursing. She's a nurse midwife and an IBCLC. She's the clinical director and lead faculty of the UC San Diego Extension Lactation Program. She's been working with families for over 20 years as a nurse midwife and lactation consultant in a variety of health settings. We also have Dr. Kelly Koka. She is a nurse and a midwife as well as an IBCLC since 2008. She has a passion for research that helps to promote and increase the knowledge surrounding breastfeeding. Not present today is Dr. Barbara Tidman Sartorio Carmago. I'm sorry I butchered that, but she just had her baby.
Yeah.
So that is why she's not here. So join me in welcoming this amazing group.
Thank you very much for the introductions, and I'm going to be using this because that's how they are recording online. Nice to see you all. It's so great to see you here and people interested in technologies for lactation care. We already were introduced, and just as a reminder, conference photographing, taping is not allowed. And I want to note that there's no financial or personal relationships that are a conflict of interest. We just want to make a disclosure that Dr. Kelly Koka is speaking today in her personal capacity and not as an IBLCE coordinator. And the views shared here are her own and not those of IBLCE. And she does not have any access to exam materials or public information about credentials. And attending this session does not give anyone an unfair advantage to affect the integrity of the IBLCE credentials. With that, here are the learning objectives that we expect for this session. So we want to have you guys able to identify how AI is currently being used in lactation care, what impact it can have, and especially in image-based classification, patient triage, and training. And we also explore how algorithms might help identify breastfeeding complications such as abscess, mastitis, skin issues, nipple damage, and while also keeping in mind that these tools still have important limitations, and that's what we want to highlight here, so we can collaborate together to improve these systems for future applications. And also we're going to discuss how AI can support clinical decision and education when it's developed responsibly through collaboration across disciplines. And here's just an agenda. We're going to start with an introduction about current innovations in lactation support, what's the current settings. We are also going to go over the breastfeeding issues that we evaluated within our project. And section 3 is going to talk about the AI implementations itself. And finally, the future directions and conclusions of all this information that you're going to gather today. So I'm going to get the mic to Christina.
Good morning. Thank you for being here. So I'm really going to start off by setting the stage for why we need innovation in lactation care, because I know a lot of people think, breastfeeding is breastfeeding. That's when I tell people I'm a lactation consultant, that's usually what they say is, isn't that easy? You just plop the baby on. So that is true that breastfeeding necessarily hasn't changed, but modern life has. And the reality is that modern life has really developed to work against the natural rhythms of breastfeeding. Oftentimes, the parent is separated from the infant, or modern life makes it harder to access that lactation support. People are going back to work earlier, especially in the US. And so the need for innovation really isn't because breastfeeding has changed, it's because modern life is working against breastfeeding. It's making it harder. And we think that innovation using technology is really a way to provide greater access to lactation support within the context of modern life. So just to start off, kind of where we are the present, and I know all of you know this, there are lots of barriers to lactation support, and a lot of times those barriers really depend on where you live. We still have areas in the world that see lactation support as being inaccessible, whether that's because there's a lack of LCs available, there's a high cost of private practice visits, there's transportation and geographical barriers. Systemic racism in healthcare settings, that's definitely an issue. Short parental leaves, poor employer support, those are all problems that we see in various countries around the world. We also have barriers for those who want to become IBCLCs. We have the time commitment necessary to get the education and the clinical hours, the cost of education and entry into the profession versus what the potential income can be for that profession. We see that there's a lack of opportunities for clinical hours, lack of IBCLC mentors. So lots of barriers from different points of view, and there's a lot of work being done on the regional, the local area, but really for there to be a change, there needs to be a lot of time invested, cost invested, and a paradigm shift. That's what we really propose, is that there needs to be this paradigm shift in how to make lactation support more accessible, more affordable, more equitable. So we propose that technology is one way to do that. So here's the future. We really have seen an evolution of the use of technology, and we have COVID to thank for that. Because when COVID happened, people weren't able to get in-person visits. They were isolated, not able to get around family and friends support, all of that. So a lot of lactation support had to go to telehealth. And telehealth is probably how you have experienced technology already in your profession. Really, telehealth, I will say, myself included, was met with a lot of mixed emotions. A lot of lactation consultants loved it because it created more access. It allowed people to continue getting support even when they were stuck at home. A lot of LCs didn't love it because it was hard to make these connections through a screen, or you weren't able to do a hands-on assessment. But regardless of what our personal thoughts are around the LC, what researchers have been trying to answer, the question they've been trying to answer for the last 5 years is, does telehealth or this use of technology increase breastfeeding outcomes? Does it prolong breastfeeding duration? And the answer is yes. So we have seen how telehealth has really improved where it provides access in a way that other people haven't been able to experience it, whether that's, even now, we don't have a pandemic on the same level, but still people are using telehealth when there's geographical issues such as rural locations, or, I mean, lots of LCs will even see clients that live in other states or other countries, and they're creating that access. So there is a way for telehealth to work, but there's also still barriers, as you can see. And what we really want to recognize is that telehealth in and of itself is not enough. We still see some technical barriers. We still see limitations in access to lactation support, because even though telehealth might expand access, we don't have a lot of lactation consultants to begin with. We still have this decrease in lactation support, and how can we really utilize technology to expand lactation care, improve breastfeeding outcomes, increase provider efficiency? And that's the project that we're going to talk about today. We're hoping is one way to facilitate that. Artificial intelligence is really what our project today is talking about. So telehealth kind of set the stage of introducing technology into the lactation space, but we're going to take it up a notch and move it all the way to artificial intelligence, or AI. Because telehealth isn't enough. And AI, I know, sounds really scary. I'll totally admit it's not my favorite topic. When I first heard about it, I was like, ooh, I don't know if I want to do that. But it's already being used in the lactation space with really good results. So just to highlight some of the ways it's already being used, it's helping to predict breastfeeding patterns or predicting breastfeeding sustainability for dyads or where they need more support. It's increasing, or it's already analyzing milk composition. It's providing more lactation education. It's actually standardizing. It's helping to standardize lactation education. So other ways that it's being used is also creating more consistency and more standardization so that there's more continuity of care for different providers who are seeing the same clients. In the profession, lactation is one of the healthcare arenas that we don't have a lot of standardization, and so AI can really help with that. It's also being used to provide education not just to parents but to other providers, and I think that that's a real benefit. It's helping providers themselves become more time efficient, have more accurate assessments, and our particular project is really looking at specifically nipple trauma and how AI is being used to identify issues so that providers can create a more efficient, effective plan of care. So Kelly and Jessica will talk more about that. If you get nothing from this talk, though, I hope that what you get is that AI is not going to replace IBCLCs. That is not the intention. None of us want AI to take our jobs as well. So there's a lot that AI can do and a lot that it can't do. AI is going to improve our time efficiency. It's going to increase our training. It's going to create more standardization. It is not going to take away the need for a lactation consultant. It is not going to distract the parent from their infant. It's not going to increase parental anxiety. It's not going to interfere with infant bonding between infant and parent. So I want to reassure you if that's your fear. And so now I'm going to turn it over to Kelly, and she's going to talk about the clinical data that was collected and the breastfeeding issues specific to this project.
Thank you. Well, in clinical data, we have the most common breastfeeding complications that may be suitable for AI-based assessment, focusing on condition of the breast, nipple, and areola, in contrast of the half breast and nipple, so we can compare, we can use this as a normal one to compare what we have in different situations and then, for example, in contracts, including it contrasts the appearance of half nipple with several clinical presentations, including dermatosis, engorgement, mastitis, abscess, nipple bled, nipple damage, as such as fissure, erosion, crust, and nipple blend, nipple, and irritation. Each condition is characterized by just distinctive visual features such as redness, swelling, peeling, fluid collection, or small change in skin tone and texture. The overall goal is to demonstrate how visual pattern recognition can assist both healthcare professionals and artificial intelligence systems in the early detection and management of breastfeeding complications, ultimately providing maternal care outcomes. In common breastfeeding complications are well suitable for AS assessment because each condition shows distinct visual pattern that can be captured with a smart phone, for example, not expensive equipment needed. And these images provide enough information for disease classification, triage, and deciding of follow-up care, of course, based on the literature we have at the moment. So, and the most and some of current tools we use it is the classification of nipple trauma lesion based on the dermatology dictionary, medical dictionary of nipple damage, or in general tissues, and trying to analyze the nipple area lesions in Brazil. In our study, this classification instrument we had published recently, and also try to use the AI to support us in level of trauma. For example, using the NTS tool to give us the stage of the damage in the nipple, and we can combine that with some symptoms and other clinical conditions, for example, nipple pain scale, in the visual analogic scale, or even though the latch tolls to breastfeeding quality. So most assessment really on visual evaluation, patient reports of pain, and observation of a breastfeeding session, all of which can be subject and vary between professionals, so that could be a way we can follow this according to literature review. So for example, we have this this picture created by Jessica, which shows the patient interface here. You can see the patient can use to capture the image here, and the system will read it according to the coordination. The system will read it and give us the idea what happened when, for example, when she is from far place, or she can give us, because some of time what we have is the patient come to us, send a message. In Brazil, we use a lot of WhatsApp message, and how we can target the women, who is the first, who sent me at the midnight, or, and that could be support us to give us who I have to assess first, who is giving me need more attention first, not just following the time, or the who say, oh, I'm happening something to me, help me, but you can use that for manage that situation too. So also the system, they can support us, for example, here. It can provide us the self-care information according to the analysis, and also given them information, you have to go to the hospital, or I have to go to there as soon as possible to see how can I help the women. So for effective triage system implementation, classifications tools need to be standardized, terminology keeps consistent, and severity levels carefully studied and validated. So even with all AI systems, the provider remains in the loop. IB CLC expertise continues to be essential for comprehensive breastfeeding evaluation, infant assessment, including latching, sucking dynamic, optimizing positioning, particularly when trauma is present, addressing emotional and cultural factors that influence feeding success, and providing individualized resources and support for to mothers. So our AI systems beyond the clinic could be technology, have the potential to enhance lactation education, also provide standardized assessment tools to support students' training, facilitating remote technique teaching and supervised practice, and promoting confidence and competence in clinical breastfeeding and evaluation. So, but the data collection, some challenge we have to address using AI in data collection, in quality data needs for AI and ethics consideration. In data collection, we have poor image quality in healthcare, and a system data sets could be a challenge for reach where we want to exactly what happened. Privacy concerned affect data set size and algorithm accuracy, and lack of standardized technology and assessment affects clinical consistency and algorithm precision. In data quality need for AI, proper image acquisition guidelines, diverse demographic representation, monitor healing progress, and use of validated outcome measures. And for ethical consideration, informed consent for image use, data security and patient privacy, and respect cultural norms. So addressing data collection challenge, many of these issues can be reduced by fostering collaboration between lactation consultants and technology developers, improving data quality, and providing ongoing feedback on the use of AI tools. So now I'll give Jessica to speak to go into deep dive into technology. Thank you.
Thank you, Kelly. I hope I was able to reduce the terms enough so it's easy for the audience because when we think about AI, we think that is something very complicated, or right now we think about ChatGPT, but really we don't know what is AI, or we think that everything is AI if it's a website or a software, and I want to clarify that. So AI has been used in many sub-areas of medicine, helping to classify and diagnose, especially in imaging evaluations in dermatology, in ultrasounds, x-rays, and why not bringing that for lactation care, right? And imagine that this is an onion of technologies, and AI is the external layer of the onion. AI is a broad field that includes machine learning, and then within machine learning, we have deep learning, and here are the models that are parts of convolutional neural networks, which is what we use for image classification. We have large language models, which is ChatGPT, that is so famous right now, and we have also generative images, generative neural networks, which is to create artificial images or artificial data for us to also use for some AI assessments, and also for recurrent networks, which is for audio and speech interpretation. So ChatGPT is here in LLMs, and what we are is here that I'm going to talk about in the next slides. And for us to know the difference, let's look at how they fit together. So the AI is the big idea behind the smart machines, and they normally required human in the loop. So we tell the machine how to reason, how to learn, and how to make decisions. When we go down into that layer of the onion, we have machine learning, and it's a branch of AI that we still have to tell the machine how to learn, but it can improve with time by itself. And we don't really have to reprogram a lot to have that performance improvement. And then with deep learning, it's a part of machine learning that I like to make an association of this with our brain connections, neural connections. Because it really has several layers of different knowledge absorption. And it learns detailed features from the data, such as images, sound, or text, is those little circles on the onion. And what we worked with, it's called convolutional neural networks. And I love using the example of dog, cats, and birds because it's very easy for us to understand how we can train a machine with enough information such that it knows how to recognize patterns between dogs, cats, and birds. So these boxes in an AI model, it's each one of those neural layers that is the circles with the wires between the connections, and each layer is going to learn a specific feature from the images. So some of them are going to look at the edges of the animal, some of them is going to look at the type of fur, or if there is if it's a bird, if it has the beak. Yes, thank you. Or if there is a nose, it could be a cat and a dog. So those features, right? And what we do when we are training this data, we need a lot of images of diverse cats and dogs, several images. And then when we train that model with that thousands of images, the model by itself is able to decide whether or not there is a dog, a cat, or a bird. And it gives you an estimate of how certain the model is. And also it gives you the percentage of other conditions, right? And that's how we evaluate the performance of these models. So confusion matrix is an example that allows the developer and also people to know where the model decided the right thing and also where the model made mistakes, right? So the AI think that this might be a cat, but it's a dog. So I put the analogy of the wrong animals because that is exactly what happens in AI. It learns the wrong features, right? So when we looked at a confusion matrix is how the model confused. And the main diagonal is what we noticed that it's where it's supposed to have the right estimations, and whatever is wrong is the false positives and false negatives. And that's how we are able to evaluate what are the areas where the model confused the most. So bear with me with this, because later I'm going to show this with actual lactation examples. Just breathing for a second. So as I said before, with the dogs and cats example, we need a lot of data, but not just any data. And we presented a post yesterday about the guidelines about how to acquire clinical images for lactation-related concerns. Because if we teach a machine with bad examples of images or bad quality, the model can learn the wrong features. So for example, if we have an image with a glare, we can think that the glare could be a issue like a fissure or a crust, but it's just a glare. So we want to make sure that the image is as clear as possible so the model can learn the true features of it. And for that to happen, we need to collect data in a consistent way. So that's why guidelines have been proved to be used in dermatology and other fields, and we want to bring that to lactation so this can be used not just for AI models, but for other applications. So now I'm going to talk about what we did. And I just want to highlight that we have another person here, Maya Nakamura, that also worked with this. And it was so nice to find out that we work on the same thing, and now we have to collaborate. So her work is also cited here, just so you know, if you want to look at it later. For our work, we did 2 studies. We have a multi-condition breastfeeding issue detection. And then the second study was using just for nipple damage classification. And the 2 studies are different, but they use the same convolution of neural networks to be evaluated. So we know that what our theory work in study 1 was validated if it actually works with a practical clinical data set. So the first study had 1,078 images. They were online and printed resources. We did search on YouTube videos, in forums, and other resources, and tried to search in many languages so we can imitate the geographic diversity that you would find globally. And it was 1 year of data collection, and we were able to find 1,078 images. And we did data augmentation and sampling to have 6,400 images. I'm going to explain what augmentation is soon. And then for the clinical trial data from study 2 from São Paulo with Professor Kelly, we use images based on the Ilca tool, which is the instrument for lesions of nipple areolar issues. And we had 1,090 images, and we did data augmentations as well. But we had more images because we added a couple more augmentations. So what is data augmentation? So when we receive an image from the clinical study, we need to crop and show the region of interest, which is what we're going to show the AI. This is a nipple damage. So we don't need that information around. We don't need to show the breast or the areola unless we are assessing conditions on the breast. And here we perform some changes, which is we're not changing the features of the lesion, but we are changing variations of lighting, of stretching on the image, contrast, zooming, and this is gonna give variety of different angles. So if we train the model with a crust on the top part of the nipple, but the crust happens at the bottom, and if we don't teach that variation to the model, the model might not be accurate. So we teach that so we can look everywhere, and we don't have to have one picture in every place. So that's how we mimic. And this is probably the most complicated slides, but I'm just gonna go over very simple. This is a architecture of the model itself. So we have a way to validate in AI algorithms that's called stratified k-folds cross-validation, which basically all of those 8,000 images, we split them into, imagine like a library shelf. We have the first top shelf that we use for the evaluation. When we're done with that, we go to the second shelf. And we do that 10 times so we can get varied splits of the data so we don't bias our model. So if the model has one specific person with a very unique erosion issue, and we have a different erosion at the bottom, we don't have that model memorizing the user. So we do that to make sure we don't have bias. And we loop the training model for several times. It takes a few hours actually to do this because we really want to be very meticulous with the training model. So once we have the estimations after 100 times running the same training loop, we can compute the metrics. Can the model on a separate test set evaluate 10 times? Is it gonna be right the 10 times? Or how wrong the model is gonna be across each evaluation? So that's how we do cross-validation. It's more complicated than that, but I hope it was good enough to make you guys understand. Yeah. So here are the studies results. So the first study, we had 2 tasks. One of them was called binary classification, where we just say yes or no, there is an issue happening. And then the second task, we actually separated the healthy images within separate different kinds of issues. And as you can see, remember that confusion matrix, the main diagonal is what matters for us, and also how right the model was during that whole time, right? So when we trained different models, we saw that one of the models had 95% training accuracy and validation, around 93%, but 87% of the time, it had good accuracy. But when we expand that to a more specific estimation, the accuracy is a little bit lower because there's features that are present within the conditions. But if you compare healthy to unhealthy, the model can recognize that there is something wrong. So when we think about mastitis spectrum disorder, abscess, mastitis, engorgement, there is some variations in between that are not good enough. Let me see if I have the slide here. Abscess and mastitis, yes. So when we see that when a mastitis image is being diagnosed and it's 22% of the time is being wrong, it's because in mastitis, we cannot just look at a picture. We need symptoms. We need to see if there's a fever. We need to see pain levels. So this is also just confirming that clinical practice is not just visual, right? We need more data for that. But this maybe can be good enough to inform a provider or a patient that you might have something and you need to get yourself checked out. So we need to be aware of this might not be perfect, but do we want it to be perfect, or we just want it to be informative to have additional decisions? So this is one of the examples of the mastitis, and the same thing happens between nipple bleb and nipple damage because it's conditions that happen on the nipples. That's why we made study 2, to make sure that how does the model work when we separate nipple conditions? And then also healthy and engorgement. Also, engorgement might not be an issue itself, right? But it might not be mastitis. So as an engineer that is objectively looking through features of a data, engorgement was a very interesting thing because I learned it is not an issue, but it can become an issue. And it's another thing. Do we want to make sure that if it is if the model is assured that there might be a mastitis or something wrong, do you want to talk to your provider about you might have over milk supply, you need to do something. So it might be a condition for calling for action to the patient, right? And when we talk about study 2, the study 2 categorized, we had 2 tasks as well, whether or not there is a presence of a nipple damage or not. And we had the second task about separating the conditions. So we had fissure, crust, erosion, and we had irritation. Irritation had the umbrella of erythema, edema, vesicle, and there is 3, yes. And interestingly, the work from Maya, she was able to have enough images of the irritation class And because we didn't have enough images of that, we put everything together as this lesion that did not disrupt the skin barrier. So about the results, we had really good identification of whether or not there is a presence of a lesion. Around 95% of the time, it can tell if there is something wrong. And when we expand that classification between what is wrong, and we do have some confusions between fissure and crust, because the crust can be a fissure that is healing, and it will show certain features. So it was very interesting to work with this data set, because the way the data was collected in São Paulo, it was pictures being taken of the patients in the first 3 days postpartum, and every 12 hours, they would take a photo of that patient. We have a lot of lesion progression throughout the days. And there might be some features that the model is not sure about the progression for fissure to crust. And also, one of the things that I was talking yesterday on the poster was that there is a lot of biological markers on the nipple of this population that you could see, what is it called, raspberry nipple, that it has some curves. And that variation between the curves, it might be confused with a fissure as well. So this kind of data requires a lot more annotations or other computational methods so we can have a better results. But this is promising already. And it's something that it was very exciting to see that on the clinical setting, we got even better results than with the theoretical first study. And here is something called heat maps. So the colors that are warmer, it's where the model is looking to make a decision. So if the color is blue, is where the model didn't pay too much attention. So when we see that there was a correct estimate, we could see that the model looked at some features at the right location, and for crust as well, for erosions. And when the model had wrong decisions, we could see that this heat map is looking to locations that are not related. So this is just a way to help the user that might have an interface to see where is the model looking to help them make a decision, right? Because one of the things that this study taught us was how even with these tools, the clinical judgment of the provider shouldn't be affected. This should be helpful, but not affecting the judgment. Yes. So considerations for providers. The AI mediation can assist with the standardization of the assessments, and it can be available to use anytime and can support mothers between provider visits on those days where there might be something going on, but I have a consultation next week. But if I have something wrong, I might be able to see my provider sooner because the algorithm could tell the provider that you might have to adjust your schedule for that patient. But how reliable are these tools, right? We saw that the accuracy, we still have a lot to work on, especially because the data is so limited. So my call here is let's collaborate and make better data sets so we can actually have better reliable tools. But when we did a small survey, and this is just one preliminary results with 65 nurses in Brazil, and there is some trust issues with AI. Yeah, so they moderately trust or trust a little, but not everyone trusts mostly. And that is actually makes sense, right? We have to put our clinical judgment first, and we also have to be careful about what is needed for effective and reliable tools, right? We need training and education for providers and lactation consultants on how to use these tools properly. We need to be able to discuss AI insights with patients. So there's something new showing up in the medical field that is called explainable AI, which is the AI actually telling the provider how did it make a decision and why. And we need to bring that to the patient as well, because the patient would be, are you using AI, but am I getting the right treatment? And can I actually trust what are you judging and what I am seeing in the algorithm? As I said before, keeping clinical judgment central to care, and also regular model updates of the algorithms, and make sure that providers know how to recognize errors, the hallucinations, right? When you talk to ChatGPT and it says something completely unrelated, it's a hallucination and you have to recognize it. So future directions and conclusions, we are almost done. So the main takeaways of this presentation and our work is that first, there are real barriers in accessing lactation support. If we think about the US, I feel like is one of the countries that has the most lactation consultants, but in Brazil, it's still getting there. There's a lot to work on. And if we think about rural communities, if we think about clinics that don't have lactation specialists, but there are the nurses that have to forward the mom to have some action. If we think about that, technology can help bridge the gaps into this knowledge by making care more available and consistent. Also, AI can be a valuable tool to support triage, decision-making, but it will not replace provider. This is to help in between consultations. This is to help with the providers that are not just lactation consultants, but are also doulas. They are attending births. They are doing shifts in the hospitals, and then they look at their phones and they have 10 patients to look after the shift. So helping them organize. In the US, we have health systems like Epic and MyChart, but think about other countries, we don't have that technology, like that website structure to help the providers. So we could use some of these tools to also help them organize across the globe. And finally, deep learning and AI algorithms show strong potential for identifying breast and nipple conditions, but achieving accuracy and building trust depends on using high quality data and keeping the provider in the loop to help us having expert opinions and evaluations throughout the time. It's not something that we're just gonna have that image and then we don't need anyone anymore. There's always new assessments, there's more details and things that engineers will not recognize, and we need the providers to work together so we can build better tools. Future directions. This was the end of my dissertation, and there was just 10 different things that we could do. And there's just not enough hands for that, so we need to make more work on this. So what is next for us? We do want to promote and foster collaborations, bring together researchers, clinicians, technologies to create new applications that can truly make a difference in care. And one of the priorities is to use technology to support equitable access, making sure everyone benefits regardless of background or location. We also focus on ethically algorithms, minimizing bias by having data from different places of the globe, and keeping the needs of lactation consultants and patients at the center of the development. In computer science, we call this human-centered design, and I call it woman-centered design because it's for the mothers and the providers. And finally, we plan to test how reliable the algorithm is in real clinical settings and explore how it can help guide specific treatments, because depending on the issue, we need to apply different medications, different topical creams, or even laser therapy, which is one of the works of Professor Kelly. And it's so exciting. Like, imagine having a specialized identification can help with targeted treatments. And it's better outcomes for the mom, is less time in pain, is less duration of lesions, which is amazing. So just to finish this presentation, I want us to keep the conversation going and believe in the power of interdisciplinary collaborations. Because as a person in engineering I always try to bring the collaborations with providers, because there's so many things that the engineers don't know, and there's amazing things that we could be doing for science and health. And this is something that we should continue, keep developers on the loop. And so this is our contact if you want to reach out, and our institutions. And thank you very much. And here is our references if you want. Thank you.